A warm welcome to Dr. Carrie Henning-Smith, 2026 president of the National Rural Health Association. I'm assuming that's the board of directors. We're going to talk about that in just a minute.
Yeah.
Co-director of the Rural Health Research Center. We're going to learn about that as well. And as if she's not busy enough, associate professor at the University of Minnesota. So first of all, it's great to have you on the podcast for your very first time, correct?
Yes, my first
And
time. I've listened, but haven't been a guest
great.
before,
Well,
so
how
I'm
about that?
excited.
Well, it's exciting to be able to be with you in the studio today. And Dr. Henning-Smith, why don't you talk to us a little bit about your appointment as president of the NRHA and your role there? What does that consist of? And then what do you do at the University of Minnesota? And I guess at the end of the day, why did you choose this work?
Yeah. Just a few questions there.
Yeah,
So
exactly.
my role in the National Rural Health Association is being the current calendar year president. We hold that role
Yeah,
for the year, so January 1st through December 31st. I'm just about midway through my
nice.
role right now. And as president, I preside over the board of trustees. We hold monthly meetings, and then we have three times annual in person meetings that coincide with National Rural Health Association events. There's the Policy Institute in DC in February. We just had the annual conference in San Diego in May,
Yes.
and then we'll have the Critical Access Hospital and Rural Health Clinic conference in September in Kansas City. So I have roles as president in each of those events, helping to plan and facilitate the meeting, but also presiding over board meetings during those meeting times too.
Yeah. And I think it's important to note the work that you're doing at NRHA is incredible. And it's not like we've had, any national news like One Big Beautiful Bill or other challenges that we're tackling, but the work that you do and your team each year in your conferences is pretty remarkable. They're very well run, and you bring a lot of content, to the consumer, specifically rural hospitals that are struggling today, and learning strategies and techniques about how to remain open in this very volatile situation. So that
Yeah.
that's NRHA, and we'll talk a little bit more about some of the work that they do. But
hmm
now you do this work as an associate professor. What does that look like?
Yeah, so I'm an associate professor in the Division of Health Policy and Management within the University of Minnesota School of Public Health. And with that, like any faculty position, I do a lot of research, but I also teach and mentor and advise and am involved in service and administrative roles too. So no 2 days are the same. There's always a lot of variety. But one of the cornerstone pieces of my work there is to direct the University of Minnesota Rural Health Research Center together with my colleague, Dr. Katie Casamano. We co-direct that center.
Nice.
And so I think we're going to talk more about that center
We are. Yep.
too, but
We are.
but that's a big part of my faculty role. I also teach courses in rural health, and I advise master's and doctoral students who are interested in health policy issues.
Yeah. So, Dr. Henning Smith, you just didn't wake up one day and say, "You know what? I think I want to do all these things in my life." What led to your passion to do this?
It was a long and curvy journey, as many of us have. I think my undergrad degree was in international relations, and I thought I was going to join the Peace Corps and work
Oh,
around the
wow.
world, but I decided to go in a different direction and became really interested in service issues here
Hmm.
in the United States. So instead of the Peace Corps internationally, I did AmeriCorps
Oh,
right
yeah.
out of
Yeah.
college.
Yeah.
And then following that, I was interested in social services work. So I went on to get a master's in social work, but also got a master's in public health at the same time from the University of Michigan. Go Blue.
Oh, go blue. Yeah.
Uh, and did that fully intending to go into clinical social work. I did a 12-month internship with the Ann Arbor VA.
Oh,
I was
wow.
doing
Wow.
outpatient psychiatry work through my internship there, and I loved it and I love the clinical work, but I realized that for me, I was bumping up against frustrations that had to do with policy and structure. And so that led me to want to go back and get a PhD in health policy so that I could better understand the systems that people operate within and how to improve them to give everyone a better chance at health and quality of life. And then the rural piece comes in. I grew up outside of a small town in southern Wisconsin.
Oh,
I have
sure.
rural roots across the Midwest and grandparents from rural Nebraska and Iowa and Illinois. And so I come by that naturally, just a real
Yeah.
interest in rural spaces, but also in how all of our contexts impact
Yeah.
our health and quality of life.
Yeah, what a dynamic background. And so I'm so excited to get into our discussion today. And before we get into the meat and potatoes of our discussion, we like to humanize our guest because we have people listening across the country and they don't know you. And so we want to relate to the listener. And so we often ask our guests to tell us a fun fact about themselves. We learned about, all your background, and that's amazing. But a fun fact, maybe something interesting about yourself that will connect you to our listener?
Well, this is related to what I just said, but a fun fact is that I've lived all over the country. I've lived on both coasts and across several states across the Midwest. I've also lived for various periods of time, sometimes just a couple of months, sometimes a little longer in parts of Central America and West Africa and in China. And I'm just deeply interested in understanding and experiencing different places and cultures and people. And I love hearing other people's stories of how where they've been has shaped where they've ended up in life
Yeah,
too.
yeah. Great stories that have been told. Certainly, I've heard a lot of them, and it does
Hmm.
shape. It does shape us, doesn't it?
It
Shapes our
does. It
outlook
does.
and sometimes our outcomes. So
Yes.
excited to jump into our topic here today. And for those just tuning in, we're talking about rural healthcare and aging. Dr. Henning-Smith will share her experience providing aging care in rural communities and her research into the social infrastructure of rural health. We'll talk about caregiver burnout, Medicare access, and of course, what all of this has to do with rural health. So let's jump right into it.
All
Um,
right.
so we just heard a little bit about your background and the work that you do, but in addition to your work at the Rural Health Research Center, you also indicated that you're director of an interdisciplinary network on rural population health and aging, and that's how I was first introduced to you. I read your
Hmm.
background. I had a chance to read some of your work and learn about the work that you're doing. And of course, as board president of the NRHA, all of that folds up together. But, those are leadership roles,
Hmm.
and it takes a tremendous amount of time, effort, and energy. So tell us about, specifically these leadership roles and how they all intersect, because that's what's going to be very interesting. And how do each of these organizations that we just talked about uniquely represent their respective communities?
Yeah, it's a great question. I love looking at the intersections of things, whether that's organizations and my specific roles or broader
Yeah,
issues in society. And I'm a firm believer that there's always a connection
there
point.
always
And
is.
so for me, I can find connection points across these. The central connecting point of all of those roles that I hold is a deep interest in rural health, and that's in improving access to care, addressing social drivers of health, addressing issues around aging in place in rural places. I bring all of those interests into all of those different roles that I hold. But the specific flavor of each of those roles looks a little bit different. With NRHA, it's board meetings and
Sure.
working closely with the NRHA staff. With INERFA, that's what we call that acronym for the Interdisciplinary Network on Rural Population Health and Aging. That is a network funded by the National Institutes on Aging that's really meant to grow the field of scholars and researchers interested in rural population health and aging work.
Hmm.
I'm a firm believer that everyone has a connection point to
Yeah,
aging work and to rural work.
sure.
Maybe they just haven't found it yet, but trying to help people find that. And then at the Rural Health Research Center, we cover a wide variety of topics, but I do a lot of work related to rural population health and aging there too.
Incredible work. And it sounds like a lot of work, but it's, the intersection point is so important.
Hmm.
Let's talk a little bit about, and we often do on this podcast, what is the difference in whatever subject we're addressing between rural America and urban America? Okay, and when you talk about a specific issue, circumstance, condition, it has different implications in both settings. And so, given that you've worked so extensively in aging and aging experience, how is the aging experience in rural communities, let's say rural areas, unique? And
Hmm.
how is it different from the urban areas regarding, let's just talk about social infrastructures, access to care, and resources? Because we often hear about scarcity in rural,
Hmm.
but talk to us about the work that you've done in aging. And is there any relationship there that you can point to that says, yeah, there is an advantage or disadvantage?
Yeah, it's hard to give a straightforward answer to that
Yeah,
because, like everything, it's complex.
yeah,
But the place to start is just to look at the demographics of rural America compared with urban America. And we have the indisputable fact that rural places are older. They have an older
sure.
average age structure
Yep.
than urban places. And I'm guessing your audience already knows that.
They know
I'm
that. Yeah,
preaching to the choir
yeah,
here.
yeah.
And we often talk about that as though it's a deficit and a real challenge. And I like to flip that on its head and say rural places are leading the way in aging. And rural places are the places where we see incredible innovation and resilience and creativity when it comes to meeting the needs of older adults. In rural places, you will also very often find older adults themselves holding leadership positions. Maybe it's mayor or county commissioner
Sure.
or sitting on the hospital advisory board,
Oh, yeah,
any number of positions. I think that that's more common in rural
it
spaces
is.
than it is in urban. I'd like to see some data to back that up, but
Yeah.
anecdotally, I can say that that's been my experience and my
Hmm.
observation. And I think that that gives us huge advantages and a lot to learn from. And there's a lot that urban places can learn from rural about what it looks like to follow the lead of older adults and tap into that
Hmm.
expertise and that wealth of knowledge. But of course, there are unique characteristics related to aging in rural areas that sometimes create challenges when it comes to supporting people who want to stay in their community or age in place. One of those is around housing. Rural places
Yes,
do not
yes.
always have enough affordable, accessible housing. You're dealing with an older aging or an older housing stock. So not only
Yes.
do you have an older population, but you have older
Yep.
housing. The housing is not always accessible. And so, if people's functional abilities change as they age, if they need zero entry to their home, they might not have that. Rural houses are more likely to have steps at their entry. There are structural issues there that are not insurmountable, but do require resources. They require some investment to modify homes or to build new homes that are accessible and affordable, and then they require labor and supplies to make that
Hmm.
happen.
Hmm.
Transportation is another big one. Sometimes when people age, they lose the ability to drive, or there are folks who can drive but don't have the financial resources to afford a private vehicle and the fuel and maintenance that comes with that. And so rural areas are more likely to rely on volunteer drivers in the absence of a robust public transportation network. Housing and transportation come up again and again and again in all of the spaces that I'm in where we're talking about rural aging. There's also obviously the healthcare piece and rural areas. As I'm sure I don't need to tell any of your listeners, rural areas have unique challenges when it comes to accessing care, and those challenges are heightened when we look at specialty care. And as people age, they sometimes develop a variety of chronic conditions
Hmm.
or other issues that require specialty care. And needing to travel long distances to access specialty care or needing to tap into telehealth both come with their own unique challenges.
Does.
Again, I don't think any of this is insurmountable. And I think that there's a lot of benefit for everyone in supporting older adults in aging in the communities where they feel most connected and most at home. We just
Hmm.
need to be creative and we need to be able to invest resources to make that happen.
Let's talk about resources because as the population ages in our country,
Hmm.
and I'm assuming every generation obviously faces that. Access to caregivers.
Hmm.
We have some generational housing, that works where families take care, but we get to the heart of the issue of caregivers. And I want to ask you, how does, we're hearing about right now caregiver burnout, right? We heard
Hmm.
about it was more elevated during COVID in the skilled nursing facility and
Yeah.
that setting than it was ever in any other time that I remember in healthcare ever elevated. And so now you hear more and more about caregiver burnout and what that impact
Hmm.
is. So I want to ask you a question about how is and how might the caregiver burnout influence, and are you seeing a relationship between caregiver burnout and quality of care for that rural aging population? So that's kind of the first question, and then I'd follow that up with, if that is a problem, which I assume it could be, how can rural hospitals whose executives are listening to this podcast today help address that and provide, infrastructures and care and support for these at-home caregivers?
Yeah. It's a really good question, and there are rural dynamics to all of this. There's a rural flavor to the caregiver issue. When we talk about caregivers, we're sometimes lumping a couple of things together, and I think it's important to pull those apart.
Yep.
There is the direct care workforce, and that's formal paid
Right.
caregivers that
Right.
might be your direct care workforce in skilled nursing facilities or home health care, other types of long term services and supports. And in rural areas, there are fewer direct care workers per capita than there are in urban areas, even though we need more of them in rural
Yes, we
areas,
do. Yes, we do.
proportionally speaking. And that puts those direct care workers at risk of burning out. These tend to be lower wage occupations, and they also tend to be physically and emotionally challenging. And when someone is being paid the same amount to do that
Yeah.
really difficult work as they might be to work at a fast food
Right.
restaurant, that
Right.
might be a
Gas
little less.
station. Right.
Yeah, a little less physically or emotionally taxing. Sometimes they leave that direct care workforce to take a different job. So there, to the extent that they're able, I think
Mm-hmm.
that healthcare executives can think about compensation and benefit packages for lower wage direct care workforce. I
Mm-hmm.
realize that there are constraints on that, but anything that can be done to support them and to make sure that they feel the value of the work that they do, because
Mm-hmm.
ultimately at the end of the day the work is challenging but deeply meaningful. I can't think of anything more meaningful than doing work for and with other humans, that
Mm-hmm.
human connection
Mm-hmm.
piece. And so acknowledging and recognizing and rewarding and supporting that work is really important. And then a huge piece of this puzzle, and the piece that I think you're asking about more directly, is the informal caregiver piece. The informal family caregivers, unpaid
Yes.
caregivers, we have lots of names for them in this
Yeah.
country, but they make up the vast majority of care that people receive. Care in their home, logistics coordinating, that transportation piece that I mentioned. And again, there's a rural piece to this. In some cases, older adults are aging in rural communities, and they may have children who moved away, who live in a different town or a different state or even across the country. And so caregivers are doing that remotely. That can be really, really
It
challenging. That
sure
can
can
be
be. Yeah.
logistically a real puzzle. But sometimes people are receiving care from someone they live with, maybe a spouse, maybe a child, or someone who lives near them in town. That can also be deeply rewarding work, but also challenging and hard. We've done work at the University of Minnesota Rural Health Research Center to better understand the experience of rural caregivers. And what we found is that rural and urban caregivers report similar levels of fatigue and
Hmm.
burnout, but also similar levels of satisfaction and
Mm-hmm.
joy and reward that they get from the work. But importantly, rural caregivers have fewer resources available to them.
Right.
They caregivers who are employed. This is our sandwich generation, people who might be working a full-time job but caring for an older parent. They might also
Sure.
have younger kids at home. Those employed caregivers are less likely to have workplace supports for them in rural
Right.
areas than in urban areas. That means they're less likely to have access to leave, to flexible work hours, to employee assistance programs, and all of those supports that are so meaningful. So, for to the extent that healthcare executives can offer support and benefit like that to their employees who they know are caregivers, I hope that they consider that.
Hmm.
Rural caregivers also have less access to other resources. They're less likely to have respite care in their
Right.
community or
Right.
a place to
Right.
plug into to get that care. And I think that that solution requires i- involvement by the hospital and the community, but also going beyond that, partnership with the local area agency on aging,
Hmm.
partnership with local public health, and thinking about how a multi-sector collaboration can better support those caregivers. And then from a healthcare perspective, making sure that those caregivers are seen as trusted and involved partners
Right.
in healthcare decisions in that relationship. I think that we're getting better at this, but caregivers haven't always been involved in those conversations. And then
Yeah.
sometimes people are sent home with instructions that are
Exactly. That's right.
confusing and
That's very true. It's very
they're
true.
left to figure it out on their own, and that is something that
Frustrating.
hospitals and healthcare
Yes.
institutions can do a lot about. They can make sure that they're asking older adults if they have a caregiver, who is that caregiver? Can that person be involved in conversations going forward? And then seeing that caregiver as part of that care team
Hmm.
and really
Hmm.
making them part of that relationship.
Yeah, great strategies. Fantastic advice that you'd give us. So, if you're listening today and you're a caregiver, there's some opportunities for you. Ask the questions. If you're listening as a executive of a hospital or a leader, you have a lot of empowerment here
Hmm.
to make sure that as patients before their discharge and the post discharge that they are receiving the information for access to, let's just say, other services in the community that exist. And that will help the at home caregiver to know that there are resources available that have been distributed or at least discussed at the hospital level. And as we study social determinants of health, it is so important to make sure that as a population is discharged from hospitals, that aging population, that they do have access to their prescriptions, access to healthy food, access to their electric bill being paid, and those things, because that is really the advocacy that needs to continue to happen. So, great advice from you on those areas. Thank you very much. Let's make a transition to mental health
Okay.
because in this country today we are struggling in rural communities with an adequacy
Yeah.
of rural health services, and oftentimes because of the lack of transportation, patients can't even get out of their community where there are no services to go to other communities where those services may or sometimes are offered, but oftentimes access and availability become an issue as well. So rural communities often lack that adequate mental health services, and it makes access to care even more difficult for a
Hmm.
population. Especially as we talk about when that transportation barrier exists, there's no public transportation, or they live in a household where there's only one vehicle and someone else is using it. We know the stories. And, I guess let's talk about those challenges. What outcomes might that lead to in an aging population if there isn't adequate resources available? What are you seeing in your research?
Yeah, it's a really important question. And of all the things I research, this is one that keeps me up at night. I
Yeah,
spend a
me
lot of
too.
time studying mental health and social
Yeah.
isolation and loneliness. And again, there's a real rural dimension to this that needs to be thought about differently than the way that we provide services in urban areas. Rural areas, and you hinted at this already, rural areas are less well served by mental health providers. The vast majority of rural counties are mental health professional shortage areas. We simply do not have enough people in mental health careers to
Hmm.
serve the population, and we know that people's needs are not being met. There are some innovations around use of telehealth and virtual care that offer some promise, but I don't think that that can be our only answer. We need to make sure that there are in-person services available to people. For rural older adults, one place that I get concerned is around dementia care and cognitive health, which is slightly different than mental health, but related, and sometimes some of the signs can show
Yeah,
up
yeah.
in similar ways. And what we see from research is that rural older adults are diagnosed with dementia later than their urban counterparts. Some of those early signs are missed. They may be dismissed or passed on as something else, and that leads to poor outcomes, higher rates of mortality, and higher rates of other complications from dementia and cognitive impairment. And then I would be remiss to talk about this topic and not mention the troubling statistics that we have in this country around suicide.
Yes.
And rural residents have dramatically higher rates of suicide than urban residents. And that gap has been widening, not narrowing
Hmm.
in recent years. That's true across all ages, but includes older adults. And that's an area that's some would say that that's the most extreme end
It is.
of mental
Yeah.
health
Yeah.
concerns, but really a red flag that we need to be paying attention
Hmm.
to and thinking about how to better meet people's needs. This might involve getting more mental health professionals into rural
Hmm.
spaces, might involve making sure that family practice providers and advanced practice providers feel comfortable bringing up and addressing mental health concerns
Hmm.
among their population, because we know a lot of rural residents might only be receiving mental health care or getting questions about mental health care in a primary care setting. They might not otherwise be seeing a specialty mental health care provider. So making sure that
Hmm.
those general practice primary care settings feel equipped to address those concerns and to have somewhere to refer to if they need to do a referral. And then to the extent that we're relying on telehealth or virtual care,
Hmm.
it's really important that those urban-based providers understand the
Yeah.
context of rural spaces. I get
Yes.
worried when we're trying to put it too much on, say, here in Minnesota, Twin Cities-based providers providing care to
Yeah.
folks in rural Minnesota.
Right.
Uh, Not to say they aren't excellent providers, but if they don't
It's a
understand
different
the
level.
context that
That's
someone's
right.
living in, how can they provide reasonable treatment
Yeah.
advice? I think that there are training opportunities there too. When it comes to this issue, I see nothing but opportunity. I think we have a lot of room to grow and
Hmm.
a lot of space to expand and do better here.
Great summary. Great explanation. We did a two-part series. Oh wow, it's been maybe 2 years ago. I had a Michigan Supreme Court Justice Bernstein in the studio, and it was such a dynamic conversation. We turned it into two podcasts. But he shared his story. Having been blind at birth, and during COVID, the shutdown and the impact to him, who was stuck in his home now,
Mm.
could not go out. And the answer solution was, let's just FaceTime each other. And he's like, hello, I'm a blind justice of the Supreme Court. Uh,
Yep.
and just him talking about like just couldn't order food, couldn't do those type of things, the difficulty. And this is a Michigan Supreme Court justice who should have access
Hmm.
to everything, right? Like
Hmm.
every assistant, every this, every that. And he found the place of despair, and he talks about it led to some depression, and it doesn't matter what station of life you're in. It
No.
impacts all of us, and we have to be mindful of the populations and serve that population, make sure they have the resources necessary. And the answer always isn't, to your point, bringing in telehealth from a big system at a big
Yeah.
city, because understanding rural it's quite unique. I mean, I've lived
Yes.
rural all my life, and so I understand how unique we are. But
Hmm.
at the end of the day, providing those resources and access to resources, he's become a champion of talking about mental health needs during, certain circumstances in people's lives. It's been very effective, but it just reminded me of some of the work that you're talking about in the area of mental health services and resources and scarcity of those resources in rural communities. So if you're listening today as an executive, nothing keeps me up at night either than talking and thinking about access for mental health services in my community. Because
Yeah.
once medicated and back on their regimen, they're productive, highly productive members of our community. But they need that intervention. They need that care. It's so important. And oftentimes when we see the elderly, and at times, there's abandonment that occurs. And
Hmm.
but we're all going to grow old, and we're all aging in place. And so at the end of the day, understanding that and having resources available are so critical. So what you're doing is remarkable. But what you're doing also is going to be impacted here very soon by some federal legislation that occurred. And,
Yeah.
we don't necessarily talk about politics, but we talk about bad legislation. And a piece of bad legislation was one big, beautiful bill,
Hmm.
absolutely gutting Medicaid in rural communities that need it the most, having significant impact on reimbursement to hospitals and providers to provide that care, and then just access to care in general. So
Hmm.
I want your perspective. We know that more than 10 million residents rely on Medicare to help cover their health care expenses today in this country. And I want your perspective of how Medicare will be impacted by the current and upcoming federal policy changes, including fiscal year 2027, which we know is that start of that budget proposal, and fiscal year 27 for that one big, beautiful bill, which is going to essentially give us Medicaid cuts to the deepest level ever in our history. It's going to gut programs that are so essential in communities. The work that you're doing, what you're seeing, give us perspective. What can our listeners expect?
Yeah, this keeps me up at night too. The One Big Beautiful Bill Act, or HR1, whatever we want to call it, the fact is that it is taking nearly $1 trillion out of the Medicaid budget. And Medicaid has been the foundation of our healthcare safety net for decades now. It's the avenue for millions of people in this country to be able to access care. It also plays a disproportionately important role in rural areas. Rural residents are more likely to rely on government payers, including Medicare and Medicaid, than urban
Absolutely.
residents.
Yes.
And rural residents already have higher rates of being
Yes, they do.
uninsured. So our safety
Absolutely.
net wasn't even strong
Wasn't even
enough to
strong.
catch
No,
everyone.
absolutely not.
And now we're cutting that back, and those cuts are going to hurt rural places even more than they're going to hurt urban. They're going to hurt everyone, but they're going to hurt rural more than urban. And for healthcare facilities, I'm sure I don't need to tell your listeners this, but for healthcare facilities, it's going to be extremely painful to the bottom line. And I worry a lot about facilities being able to maintain services at all, or even keep their doors open if they lose more government funding. We know a lot of facilities are majority government payer, Medicare and Medicaid. Being those main payers. And if we're seeing cuts in Medicaid rolls, that's going to make it hard for rural
Yes.
facilities to stay open. So I'm deeply concerned about it. We've also done work at the University of Minnesota Rural Health Research Center in recent years looking at medical debt.
Mm-hmm.
And medical debt is one of the downstream effects of not having adequate healthcare insurance. Medicaid is one way to prevent people from having catastrophic medical debt. But again, not enough people have the health insurance that they need. We're going to see more people become uninsured, more people on high deductible plans, because those are going to be the only affordable
Yes.
option. And that's going to increase rates of medical debt. Medical debt is already more common in rural places than it is in urban. And that has all of these cascading impacts. If people have medical debt, makes it harder to afford housing, to put food on the table,
Yes.
to afford medications, and to access additional health care. We're just going to see this vicious cycle
It
until we
is.
do something much more courageous to ensure that people have access to the health insurance and the coverage that they need.
Yeah. It's going to be. We need some people to stand in the gap right now.
Mhm.
And it's
Mhm.
becoming increasingly hard to do that because of the viciousness of today's political environment, and the sheer number of attacks that we face when we do speak up. But we have to
Yeah,
do it for the voiceless, those who are
exactly.
unable to speak up. And there's never been a time, I think, in history where we need to rise up and together, make a statement about protecting the most vulnerable among us. And, several years ago, I was at the Michigan Hospital Association. I'm a board member of that group. And our president at the time, Brian Peters, said something very striking, which I often reflect on just about every day. And it was all during this big battle that we were facing with the legislation at the federal level, HR 1. It was, being
Mhm.
introduced. And we all certainly thought that there's no way this is going to pass. I mean, there's just no
Mhm.
way.
Mhm.
It's going to gut rural America. It could make the districts look even much different for congressional leaders. There's no way they're going to vote for this, and yet they did. And
Yeah.
the president of our organization, Brian, said to me, we were in a carriage. I remember it distinctively, and we were coming back from dinner, and he said, JJ, um, history is going to judge us for the
Yep.
work that we're doing. And he said, I'm committed and I'm convinced that we're on the right side of history. And I would
Mhm.
commit to you that we are on the right side. What we're
Mhm.
advocating and supporting, vital programs. And it was my party that did this gutting. I'm telling you that we in healthcare right now, and you and the advocates that we have, we're on the right side of history because
Mhm.
we know that we're going to watch this play out, and the devastation that HR one's going to have on this country and our people is going to be so devastating. History books will talk about it. So how do we prevent that? We rise up, and peacefully, without malice or without an evil tongue and spewing things like we see happening today in this country in Washington, is that we do it, that we come together for being the voice for those who do not have a voice. And so what you're doing every day is just that. I want you to know that. You are a voice for the voiceless, and you are impacting so many lives in the work that you're doing. So I want to encourage you to continue to do that. And for our listeners, you don't have to do great, noble things like our good doctor's doing. It could just be one day you go and you volunteer somewhere. It could be the next day you send a passionate email to your legislator telling them why these types of cuts are dangerous to your community. There's so much in advocacy that we all can do, and it doesn't require a big title in life. So I just want to stop there and pause to say that we are on the right side of history. You're on the right side of it. You're doing a great job. The work that you're doing is impactful, and to please continue that work that you're doing on behalf of rural America. All right, so here comes our last question.
Okay.
Um, so obviously, we're all, now that we look at this one big beautiful bill, HR one, trying to figure out what is the role of rural hospitals in this country.
Mhm.
Scott Becker, who's a frequent guest on this podcast from Becker's Healthcare, recently shared with me that the study that he and his team have done, looking at experts and using data from experts, 734 hospitals are at risk of closing in this country in the next few years as a result of some of this legislation.
Mhm.
That's every rural hospital in this country practically.
Yeah.
Very few hospitals will be propped up or can stand up. So we know that rural hospitals are facing some of the most unprecedented of times. But what should the role of rural hospitals be today, knowing we have all those other challenges in the care and delivery model for aging populations? And I guess how you answer that is to describe the steps that rural healthcare can take, the leaders can take themselves to help the aging community population access healthcare and to maintain that healthcare coverage. I know it's a loaded question. I know we could spend hours on it probably, but it's something that, all right, you've got the audience now. There's a huge listener base. Fire away. What can we do?
It is a huge question, and I think the answer to it relates to what you were just saying, whether it's hospital or us as individuals or leaders. I think we're all judged, societies are judged or should be judged on how they treat people who
Yes.
need the most help and the most support. And I see hospitals as playing a really instrumental role as a foundational part of their communities. And I think that's more true in rural places than it is in urban. You have many rural communities where the hospital is the biggest employer and the hospital can serve as a community hub. I've seen innovation where there's a cafe or a gym or a
Yes.
fitness center or gathering spaces. Rural hospitals are in a unique place to serve not only as the access point for healthcare, which is so critically important, but also as that social infrastructure that pulls a community together. And that's so important for people across the lifespan, including older adults. We know that social connection matters for your health, matters for your outcomes. And so I think that's one way that hospitals can innovate and think creatively. Are they welcoming and opening their doors even when someone's not coming to seek care? Are there
Hmm.
other opportunities to engage in the hospital space? We have these big buildings, and
We do.
often they have places where people can gather and be together. And then hospitals, when they think about meeting the needs of older adults, I think it's important to think back on the conversation we had on caregivers incorporating the not only the older adult as an individual, but who is in their family friend ecosystem, who is
Hmm.
in their network, who should be involved in care plans. That's really important. Hospitals can also look at their advisory boards and make
Yeah,
sure that older
it's
adults have
aligned.
a voice at the
Yeah.
table. If they
Yeah.
look at their advisory board and it's representing only a certain age group or only a certain demographic, and if it's leaving off people who live in the community and who would benefit from hospital services, broadening representation on those advisory boards is
Hmm.
really an important avenue. And then you mentioned this earlier, and I think it's an important point to come back to. Thinking about the degree to which hospitals can address those broader social drivers of health. We know that the majority of our health is made up not of what happens in the doctor's office or inside the hospital, but of those conditions in which we live and work and play and
Hmm.
pray,
Hmm.
uh, our communities. And so, does the hospital have a way to impact transportation or housing, or even to think about what Main Street looks like? I
Yeah.
know all hospitals have different levels of resource available to them, but hospitals, nonprofit hospitals, also need to think about the way that they're using their community benefit dollars,
It's
the
true.
way that they're investing in communities. So, thinking about those investments and whether or
Hmm.
not those investments can be used for social drivers of health to help
Hmm.
older adults and to support the overall vitality of their communities is really important.
Great advice, great strategies, a lot of hard work, and
Hmm.
communities that are committed to this will see a significant return on their investment. Healthier aging population, which is so critically important, and it really takes the leadership of individuals and hospitals to rise up and say we're going to redirect our community benefit instead of maybe sponsoring an event that has little impact to
Yeah.
sponsoring something that might. It could be some type of respite program. It could be a food bank, those type of things, really looking at the social determinants of that health. So great suggestions, great strategies today, and great work that you're doing. We always conclude our podcast with asking our guest to describe for us, what a rule recommendation would be for a new leader that's joining healthcare today. Maybe it's someone who wants to be that passionate voice. Someone wants to say, how do we get on the right side of history? You've been around, you've been in rural communities, Wisconsin, other areas. You lead the NRHA as the board president, a huge job. What advice, what golden nugget, what piece, of just helpful information could you give to someone entering, or maybe it's someone who's in healthcare now that just needs some sage advice to help them weather these very difficult storms? What advice would you give? What's your rule recommendation?
Well, this might be cheating, but I'm going to give three pieces of advice, and I think
Do
that
it.
they're interrelated. The first piece of advice is to approach this work with curiosity and open mind and to listen. And that means to the extent that you're able, visiting other rural communities, listening to people in your own rural community, making sure that you don't think you have all the answers, but that you have a lot to learn and a lot to understand. And that also means knowing that rural places are diverse.
The
Two
diverse.
rural
Yeah.
communities are going to have different issues and different solutions.
Yeah.
And I think there's a lot to be learned from that. The second piece of advice would be to get involved in NRHA if you're not already. So that's
Yes.
a
Great
self
advice.
interested plug, but
Yeah.
we saw record breaking attendance at our annual conference in
I
May.
heard
There
that.
really is momentum around rural health issues right now. And I think the time is right to get involved. And there are a lot of opportunities to get involved or even just to learn from and listen to people in NRHA in that broad more than 20,000 member community. And then the third and final piece that I would like to make sure that I include in any conversation that I have is to focus on all of the things that are going right in rural and all of the assets and strengths that we have.
Yes.
We're up against a lot of challenges. Policy is not necessarily in our favor right now, but rural communities are incredible, and there is so much hope and inspiration to take from them.
Hmm.
And starting from that asset lens and seeing what those assets and strengths are in your individual community or learning about them from other communities is a really important place to start.
Dr. Henning-Smith, I'm a big fan of yours, and having learned so much more today. The work that you're doing is so impactful. I just want to thank you because when you lift your voice up as you do on a national level, you're lifting it up for rural hospitals like Hillsdale and for those other hospitals listening to this podcast across the country. So I'm going to encourage you to continue doing the great work that you're doing, advocating, lifting your voice. It is so critically important because it strengthens the work that we're doing in rural America each and every day. So thank you for your commitment. Thank you for your service. I know boards don't pay, and so it's a lot of free time. It's a lot of work. I would agree with your statement about the conference for NRHA. They continue to get bigger. They grow. If you're listening today as a hospital executive, join NRHA. The advocacy work they do alone is so impactful. But beyond that, the programming, the updates, I love getting the NRHA update each week about what's happening. They get a legislative update that comes into my inbox, and just know what's happening on the Hill. What are they trying to do now? Getting the depth and perspective of leaders like yourself is so insightful and so very good. So thank you so much for joining us on the podcast today and for being a voice for the voiceless. It means so much to us in rural America. So thank you for joining us.
Well, it's been my pleasure, and thank you for this podcast. It's important to have.
Well, thank you, and thank you to our listeners for tuning in to Rural Health Today. Catch our next segment, Rural Health News, to stay up to date on the current state of rural health care every Monday, wherever you get your podcasts. And don't forget to check out our latest updates and resources from Rural Health Today at ruralhealthtoday.com, and make sure you subscribe so you never miss an episode. Until next time, remember, rural health strong.